Okay, this is Laura Roberts. I'm recording Chapter 10 in the F.A. Davis book for Module 4, Caring for the Newborn at Risk. We are on page 333 in the book. We will start out by discussing the circulatory and respiratory system. We talked about the circulatory system and how the blood flows differently in Chapter 9 in utero than it does after the baby is born, and the transition that happens at birth. The respiratory system, it has maturity that develops on up until term. There is a LS ratio and a PG value that's discussed here, and it's determined, the lung maturity is determined by the lecithin and sphygmomyelin ratio, and the PG, which is phosphatidylglycerol value. These are essential phospholipids that promote the oxygen that goes to the alveoli in the lung tissue. This is considered the PIP score, okay? So babies can't give us a number, of course, 0 to 10 on a pain scale, so we use a PIP score for premature infants, okay? We use this especially when they have respiratory or circulatory issues. Newborns are at risk for respiratory distress syndrome, RDS, and they will show us some signs that they're in pain sometimes. Before 36 weeks, we use the gestational age and behavior here. 32 to 36, 28 to 31, and then less than 28 here. And what they do. So you got to find their gestational age and then what they do in these boxes to give them a score. Okay? This is a wink and a lollipop. So you need to know that a normal score is 6 to 7. Okay, a normal PIP score is 6 to 7. Anything greater than 12 is when we give the baby morphine sulfate. Okay, so I'll say that again. A normal PIP score is 6 to 7. Anything greater than 12, we give the baby some morphine sulfate, IV. Okay, all right. On page 334, this is just a baby getting an IV in the scalp. I know this looks painful, but this is a really good access line. And of course, here is your wink and lollipop. But you just need to know as well that we give morphine right there. Okay. Anything that goes in the scalp, we got that skull, the bone, right, that keeps that access open and good access to veins. And so this is the NICU intensive care, and then it just talks about patient education. Okay, Carew care, this is skin to skin. Okay, the only thing the baby has on is a diaper. It's important, of course, to regulate temperature, as we talked about, right? Collaboration of care. So parents in the NICU, just read through this, explain policies and procedures, hours, different things, procedures that's going to be going on in the NICU for their baby. Education is key. Okay. Table 10.1 is talking about risk factors that compromise the newborn. Okay. The genetic order, such as trisomy 13, 18, and 21, intrapartum and extrauterine, just different issues that's going on. So be familiar with those. Okay. Let's flip over here. This is your PIP score again, your pain profile. Birth weights, so just terminology, okay? LBW is low birth weight, VLBW is very low, and then extremely low birth weight is ELBW, okay? Any low birth weight will be considered less than 2,500 grams, okay? Very low is less than 1,500, and extremely is less than 1,000, okay? There was a time if a baby was not at least 500 grams and 23 and 4 days, weeks, gestational age, the baby could not be resuscitated. Thank goodness those times have changed. Alright, on 339, just looking on, and there's this chart right here as well. So SGA, AGA, and LGA. Be familiar with that, especially for clinicals, because you're going to have that on some paperwork, and you're going to need to know what that baby is. What does that baby weigh? That's also on page 336, okay? These page numbers down here at the bottom don't always coincide with the ones in your book, but this one actually does. So, normal blood pressures on an infant is according to weight, okay? Blood pressure cuffs, TPN, you know that's total parenteral nutrition, okay, so IV nutrition, enteral feedings. This is a baby with NG tube, okay, twins, it's NG tube, non-nutritive sucking. This is just promoted for high-risk newborns. Hopefully that teaches them to start sucking when they do start breastfeeding. They'll have a good latch, okay? Skincare, extremely important. You know, those nosocomial infections in the hospital, and we do not want any of that. So skincare is extremely important in our NICUs, okay? Noise, sleep, lighting, handling, position, you know, just like you would any other patient in an ICU or CCU that can't turn themselves, you turn a baby, okay? You roll, you prop them up on a blanket from the sides, because they can get the bed sores, they can get the wounds just like any other patient, okay? This is a transport unit. Neonatal transports, they come in with the whole shebang. They got everything that they need right here to transport a baby to a critical care unit, okay? There's a program called Stable. If you'll look on page 340 in your book, it's under Small for Gestational Age, and the Stable is actually in box 10.1. As NICU nurses, we all had to be certified as a Stable certified nurse, as well as multiple other certifications, but Stable was one of the big ones. And it stands for sugar, temp, airway, blood pressure, laboratory work, and emotional support, okay? Very, very important to know what to do in those situations for your NICU patient, okay? Under SGA in your book, the second paragraph down, you have some winks and lollipops, okay? So, wink and lollipop is here. Alright. So this is talking about asymmetrical small newborns have an appropriate size head circumference that measures between 10 and 90. percent for their gestational age. So the chart plotted on the head circumference, okay? But their weight falls below the 10%. So that's what we're looking at really, is the weight, okay? Asymmetrical SGA is also called brain sparing. And of course that makes sense. You know, their head is okay, but their body is not, their weight is not, okay? Symmetrically, small newborns are not only in the 10th percentile for their weight, but also their head, okay? So they're symmetrical, and this is called non-brain sparing, okay? It's important to know. So winks and lollipops, okay? So asymmetrical, the head is bigger, of course. Symmetrical is the size of their body, okay? All right, let's look on down. Characteristics of an SGA newborn. They look like they have some wasted tissue, wasted muscle tissue, lack of brown fat. So that brown fat is what keeps us all warm and cozy, okay? They do not have that, all right? They look like they're starved almost. Like you can see their scaphoids, their eyes appear really large, long fingernails, meconium, stained thin cords sometimes if they're post dates and they're SGA. A lot of times they have issues, polycythemia, pain, cold stress, of course temperature instability, because why? They don't have that brown fat, okay? Cold stress. So here's another wink and a lollipop. Cold stress, okay? It's more likely in an SGA or preterm, okay? So know this paragraph. SGA and preterm are the ones that have the cold stress, okay? Because they do not have the brown fat. Less flex, thinner skin, very low birth weight. Water loss can be 8 to 10 times greater than in an adult, and 5 to 6 times greater heat loss, okay? Be familiar with this. Cold stress increases metabolic needs, and then they start going into metabolic acidosis when they get respiratory distress. So we really have to watch them closely, okay? Important, this is in your book, back a couple of pages, but another important factors for those baby is weighing everything, okay? We need to know exactly extremely strict eyes and nose, okay? So SGA, this is an apple, okay? This is the baby's head, all right? This is a normal baby. This is an SGA baby, all right? SGA versus AUGR, okay? LGA and SGA babies. You see the difference? You see how you can see the scaphoids, the ribs, okay? Tiny legs, tiny arms, okay? SGA versus AUGR, intrauterine growth restriction, okay? There's a difference. All right? So let's look at the prevention, okay? Prevention, another wink and a lollipop. Hypothermia is assessed at-risk newborns and at-risk newborns, and is continuously monitored while using radiant warmers for extremely low birth weight babies in incubators, okay? So you'll see one of these. This is the older one. We had these in Tifton where I worked. They're a little bit not as bulky now, but does the same purpose, okay? Keeps the baby warm, right? So winking a lollipop up here, guys. Hypothermia, okay, is assessed for at-risk newborns, for all newborns. So we know not just at risk, but for all newborns, we assess for hypothermia, right? So So, normal temperatures, okay, in a baby. Skin temperature is 97 to 98. Axillary is 97.7 to 99.5. And rectal is 97.9 to 100.4. Okay? Anything over 100.4, we're getting concerned. Okay? So we mentioned on page 344, let's look at this page. This is where we do heel sticks. On the side, never in the middle. Always on the side. Just FYI. Okay? When we're drawing blood, we draw it from a tube. We don't actually stick the baby unless we have to. We draw it from heel sticks 99% of the time. Okay? Polycythemia, we said that term a while ago, right? This is a condition where there's too many red blood cells, okay? Lots of problems can go on, all right? Hematocrit's too high, so what do we do? And why is it happening, okay? It's too much blood was passed in the intrapartum environment, okay? The placenta, milking the cord can cause this problems. Others can occur with twin-to-twin transfusions where one twin gets all the good stuff and one twin does not. Maternal factors such as smoking, diabetes, living in a high altitude, carbon dioxide exposure, lung disease, all of this can cause polycythemia, okay? Complications is necrotizing enterocolitis, that's neck, that is rotten colon, for lack of a better explanation. Jaundice, thrombocytopenia, pulmonary hypertension, neurological sequelae, seizures, cerebral infarcts, okay? Cerebral palsies can even be caused, okay? Signs and symptoms are ruddy skin, like just a ruddy red skin, okay? Delayed capillary refills, hematuria, proteinuria, and thrombosis. All right. Let's look, just be familiar with all this. You don't have to memorize it, but just be familiar with it, okay? Now, let's talk about LGAs, okay? These are babies that are large for gestational age, or the 90 percentile growth, okay? They're the big babies, macrosomic, okay? They are at least 3,750 grams, 8 pounds, 4 ounces at 4 weeks. Macrosomics are over 4,000 grams, okay? Some of the risk factors for LGAs are obesity in the mama, maternal glucose intolerance, so gestational diabetes, of course, prolonged pregnancy, going post dates, increased maternal age, increased parity. Some associations with problems would be shoulder dystocia at delivery. So the baby's too big to come through the birth canal, okay? Hypocalcemia, hypoglycemia, asphyxia, okay? And let's talk about one in particular. So this is a wink and a lollipop, hyperglycemia, okay? So, wink and a lollipop. So glucose readily passes through the placenta, but insulin, because of its molecular size, does not. Therefore, the fetus produces larger than normal amounts of insulin, hyperinsulinemia, to keep up with extra glucose. So you remember us talking about that actually yesterday in lecture. We were talking about the hypoglycemia and hyperglycemia, okay? So the mamas may be hyperglycemic. So they've got high sugars. They're not tolerating the sugars well. The baby gets the glucose and produces more insulin because it's trying to fight off the mama's extra glucose. Make sense? So there you go, wink and a lollipop. All right. Then you have transient tachypnea of the newborn, TTN. This is a very, very used term. This is when they just have a little trouble breathing to start with. Okay, very common in LGA babies, very common in preterm babies. Okay, it's where they might need a little bit of help starting out breathing. Some C-section babies, they don't get that good squeeze, so some C-section babies have difficulty clearing their lungs, and they'll have that transient tachypnea, and that's breathing fast, right? And that's when you're going to see the grunting and retractions and nasal flaring. Okay. So SGA, AGA, and LGA, you see the difference, okay? They are significantly different, okay? Let me go back to this because I don't want to confuse you. SGA versus IUGR, okay? This is an SGA baby, all right? This is extremely small, of course, okay? This is not IUGR, but this is LGA, okay? This is an LGA baby, all right? You see the difference? Now, they're the same gestational age, okay? So IUGR is intrauterine growth restriction. Didn't want to confuse you. So this is SGA and this is LGA, okay? Big babies, all right? Okay, again, we talked about this. I want to show you this video, and I know, I apologize, I went back and listened to the first video. I apologize for the reverb on the videos, but this is one that you truly need to hear, okay? It'll help if I lower the mic.
Hi, baby.
What is it?
Hi, baby. Yeah.
You see the chest? How fast he's breathing?
Hi. Hi, Trey. Hi, baby. Hi.
Okay, so hopefully you saw those retractions. I think there's a couple more videos that I can show you as well, but let's see. Yeah, here we go. So they're different grades. We don't really grade them so much anymore. So, I guess probably pediatricians do or neonatologists do. But we just chart it as grunting or retraction or nasal flaring, okay? So I want you to see this one. I'll listen to this one. Okay, and this one.
In this video, the newborn has an audible grunt giving a score of 2. Nasal flaring is visible from a distance giving a score of 2. There is seesaw upper chest movement giving a score of 2. There are some xiphoid recessions giving a score of 1 and some lower chest recessions giving a score of 1. So the total Silverman-Anderson score in this infant is 8.
So this is what we're talking about, the Silverman and Anderson Index Evaluation. Like I said, neonatologists and pediatricians use this. Just be familiar with it, okay? It's also in your book on page 346. Now we're going to talk about ABGs, arterial blood gases. And here goes the respiratory acidosis, metabolic acidosis, respiratory alkalosis, and metabolic alkalosis, okay, and the different signs and symptoms that can happen with this and why it can happen, okay. This is what happens to your pH, your CO2, your O2, and your CO3, okay. Be familiar with that. Be familiar with this one especially, the normal. What is normal? Okay? Be familiar with that one. Alright, let's go on down. On page 347, it's talking about birth injuries. Brachial plexus DPI injuries. Okay? So this is when there's a complex nerve root there, brachial plexus, and they're responsible for the shoulders, chest, and arms moving, okay? A lot of times these nerves are damaged, and that can lead to Duchenne-Erb's paralysis, Klumpke's paralysis, and the lack of a Moro reflex. And you should know what a Moro reflex is by now, okay? Look at box 10.6 on page 347, and it can explain the different degree levels for these, okay? Clavicle fractures. When we are doing our newborn head-to-toe assessment, we are feeling for these, okay? We're feeling for any type of crackling or feeling for a broken clavicle or humerus, okay? Talking about the blood gases again. Preterm newborn, okay? Many different problems can happen with a preterm newborn, okay? Be familiar with what all can happen. Now I want you to look at the signs and symptoms, okay? Remember us talking about RDS at the beginning of this chapter. Respiratory distress syndrome, right? Alright, this is a wink and a lollipop. I want you to know the signs and symptoms and the risk factors for preterm birth, okay? All of this is winks and lollipops, okay? Be familiar with it. Know it, winks and lollipops, okay? There's another chart for assessment of a preterm. Just read through this. And then, let's see. Your big ones here are rapid breathing, tachypnea, okay? Know that one. no periods of apnea, which is not breathing at all, right? You need to know that what the term retractions mean. That's the use of accessory muscles for breathing, okay? All right, let's go back. Keep on going down. This is on page 351. And some of these up here on page 351, there's a chart in between them in your book, this chart right here, okay? So on 351, this continues right here, okay? But know these right here. You need to know those, all right? So oxygen hood. Of course, this is not a baby, it's a doll, but there is hoods, okay, where we do low-level oxygen through the hoods. When we take off a CPAP or take off even nasal cannula, they'll go to an oxy hood and just see how they do before they transition off of O2, okay? So that's what that looks like. There's a drug, and we've talked about this in the past, called surfactant, Survanta, okay? Remember, this is a synthetic surfactant, okay? We give this down an ET tube, and this holds the baby's alveoli open. This is the glue-like substance, okay? You need to know this drug, and you need to know that it's given intratracheal or endotracheal, okay? Winks and lollipops. You need to know how it's given, all right? Car seat challenge, okay? Any baby that's had any kind of cardiorespiratory difficulty are going to get a car seat challenge. And they need to sit in a car seat for an hour or more, usually an hour. That's Archibald's protocol. And they need to not have any apneic spells or bradycardia or O2 desaturations, okay, in order to go home, all right? If they pass it, everything's good, they can be discharged. But if not, they need to stay and get worked up a little bit more, okay? All right, on page 353, we're talking about bronchopulmonary dysplasia, BPD. All right, this is a chronic lung disease that happens past 36 weeks. It's a complication of long-term oxygen use, especially with a ventilator, okay? It's just increased density, hyperinflation, like too much oxygen, too much pressure has been given, okay? And that can be damaging. So as a NICU nurse, you have to know what you're doing. As a respiratory therapist in a NICU, you have to know what you're doing, because if not, you can set this baby up for bronchopulmonary dysplasia, BPD, okay? You need to know that, let's see, this is a wink and a lollipop, okay? When treating preterm newborns with oxygen, use the lowest amount possible to maintain acceptable oxygen saturation levels, okay? You start low and go slow, right? And that's on anything. That's on medications. That's on anything. Well, oxygen is a medication, right? It has to be ordered. So we start low, and if they're tolerating it and they've got 95 O2 sats, even 93 O2 sats, we're going to leave it alone. We're not going up unless we absolutely have to, because we don't want this baby to have BPD, okay? Because that's a whole new battle when we do. All right? Now let's look at physiological and pathological jaundice. We talked about this earlier, the last chapter, but we're going to talk about it again, okay? We know that the physiological happens when? After 24 hours. The pathological happens before 24 hours or at birth, okay? So, winks and lollipops right here, all right? Same sentence that I told you to write down, correct? So there it is again, okay? let's look on down. Still talking about the jaundice. We're going to look at this. So this is also a wink and a lollipop. Inadequate stooling can prompt the recycling and reabsorption of bilirubin. Mothers should be encouraged to initiate early breastfeeding because colostrum exerts a laxative effect that increases meconium excretion. For all healthy infants, early feedings promote intestinal elimination and bacterial colonization and provide calories essential for the formation of hepatic binding proteins. Know that. Wink and lollipop, okay? So we need them to poop. We need them to pass that meconium, that bilirubin, because if it stays in the system, it's recycling them and making them sicker and sicker, okay? All right, let's talk about the non-physiological and pathological jaundice, okay? And this is the different levels. And remember me talking about 20, over 20 is brain damage, okay? So this is high risk. 15, we start light therapy, okay? Let's look at this one. So this is a wink and a lollipop, okay? Infections, metabolic disorders, and incompatibilities between the mother's and newborn's blood, RH incompatibility, may also cause pathological jaundice. And we talked about that, right? The ABO incompatibility, okay? ABO incompatibility within the first 24 hours of birth is patho, right? Pathological jaundice, all right? So we are going to initiate breastfeeding as soon as possible. We want to get that bilirubin out of them. We want to feed, okay? Another wink and a lollipop. Initiate breastfeeding as soon as possible, all right? Goes on to talk about the late onset jaundice from breast milk. Anemia of prematurity. Just read through this, okay? And here's our baby. We protect the eyes. We protect the retinas from the UV lights, okay? And we protect the genitalia. So we always have a mask on our baby, okay? And we always have a diaper on our baby because we protect those sensitive areas, okay? Let's talk about necrotizing enterocolitis, okay? Serious condition of the bowels, okay? Ischemia, dead bowels, like I said before. Limited access to blood and oxygen in that area. And it can happen, and it can be caught. Babies not having stools. Babies are irritable. Babies are having extreme vomiting, aspirating, even. So we watch for bowel movements and we watch how they feed, right? So just know the signs and symptoms of that, okay? We also can prevent it. So read through here and be familiar with that. GERD, okay, y'all should all know what this is. Gastroesophageal reflux disease, right? Read through that, be familiar with that. Retinopathy of prematurity, ROP, is immature retinal, okay? It's an immature retinal vascular followed by hypoxia, okay? Oversupply of O2 can play a significant role, and it did in the mid-20th century, okay? Leading cause of blindness in children was huge amounts of oxygen that were given to them. And it can be very serious. Very premature babies, medicine has come a long way, so they figured out that the overabundance of O2 has caused that retinopathy, okay? Be familiar with that term. The extent of retinal damage is dependent on the criteria, of course, okay? That was, sorry y'all, that was on page 356, okay? We're going to 358, and we're looking at post-term newborns, okay? See if there's anything else we talked about. This would be, let's go back. Necrotizing enterocolitis. You see how this, and that should have went with that. You see how this stomach is so puffy, the swelling. This is a sick baby, a sick baby, okay? This can also play into different congenital diseases as PKU. You know, they may have some type of intolerance. Some PKU babies are mistaken for hold on, y'all, I'm thinking gluten babies, okay? And usually you don't develop that until later on in life, but it can be earlier, and it mimics it. So but PKUs are definitely more significant, I would think, okay? All right. Let's go back to the homocystinuria. This is the dislocation of the eyes, nearsightedness, glaucoma, galactosemic, where they don't metabolize stuff. This is just different type of metabolic diseases is what I'm talking about here, okay? Go back in your book. So post-term babies on 358. Let's see. Are over 42 weeks, okay? 42 weeks or after gestation are considered post-term, okay? Signs and symptoms. The biggest one is dry, cracked skin. If you want to write that in, this little, besides signs and symptoms, you'll need to know that later on, okay? Meconium aspiration. You know, meconium is the first bowel movement, and sometimes it happens in the womb. Sometimes it happens before, like transitioning. They suck that fluid in, and it's meconium stained, and then the meconium gets in their lungs. Do we want anything in the lungs besides air? Absolutely not. So we have problems. Sometimes that's our TTM babies, our transient tachypnic newborn, okay? That happens because we got to get all of that meconium out of their lungs and clear their pathway, clear their airway, okay? So just read through that and be familiar with that. On down, let's see, on page 361, it starts talking about this newborn screening, and that's what's over here, okay? Just the different types of things that can happen. Phenylketonuria, galactosemia, okay? Homocystinuria, cutaneous findings of the biotinase deficiency, and that's on 360, 361. Congenital diaphragmatic hernia. You see how all the bowels, all the intestines are up into the chest cavity, okay? Diaphragmatic hernia. So that there's a hole, huge hole there, okay? When I was telling you about checking the palate, okay, this is what can happen, all right? We can always see, of course, a cleft lip, right? With a cleft lip, there's always a cleft palate. But is there always a cleft lip? Is there always a cleft palate with a cleft lip? No. Okay? So, always check. If it's gonna cleft with the lip, it's gonna be there. But if you don't necessarily have it, you won't know it unless you check it. Okay? All right. This is gastroschisis. This is where the intestines are born or outside the baby, okay, outside the newborn. All right. We cover it with saline and we get them to an OR as quick as possible to get everything back to where it's supposed to be. Okay. All right. Let's look at page 362. And you can read through all of the thyroids and all that, okay? This is 362, okay? I want you to be familiar with what ancephaly is. This is a condition where there's no skull or cerebrum, okay? They're malformed. Encephalocele, okay? Neural tube defect, where there's a brain that's protrusion through the skull, okay? Some of it can be missing. Some of them can survive after rebuilding the skull, but some of them succumb, okay? Microcephaly, this is a small brain, small head, okay? Be familiar with these terms, all right? Cleft lip and cleft palate, again, they're special bottles that are made, and this is the Haberman feeder for cleft palate and cleft lip babies to drink out of. They suction different than normal babies. The diaphragmatic hernia again. Talked about the gastroschisis. This is on page 364, guys. Just read through that. Prevention. And then table 1011 on page 365. Okay. That's the one that's here. Just be familiar with that. The most common causes of neonatal sepsis. Okay. Broken down. All right. Streptococcus. When a baby gets group B strep from the mama, remember the mama has it. The penicillin, ampicillin G is the treatment. So your mama has GBS positive or negative, right? Group beta strep. She's either positive or negative. Nothing that she's done. It's just a normal natural flora bacteria that lives in the bladder and the vagina. Okay. If the mother is not treated during labor, the baby can contract group beta strep. Does it hurt the mama? No. Does it hurt the baby? Yes. Yes, yes, yes. So, you have to treat the mama in order, of course, for the baby not to get sick. These are some of the symptoms, okay? Sepsis, fever, change in heart rate and respirations, pneumonia, meningitis. 5% of babies die from GBS that get it, okay? It can be and 5% doesn't seem like a lot, but that's a lot, guys. Late onset, person to person post birth, 3 months is less severe, okay? So just make sure there's greater than 25,000 incidences in the United States every year, okay? And this is a baby on the vent that is GBS positive, okay? That is on page 365 in your book. It's talking about under the nursing insight, okay? It's talking about the GBS stuff, okay? Right here, 365. Differential white band count. So, if we see a difference in the bands, like if you draw the mama's blood or the baby's blood and the white cells go up, here's just a little formula that you can use to figure out, is that a significant increase or decrease, okay? All right, on page 366, we're talking about developmental delays, the NAS, neonatal abstinence syndrome, okay? And this is more common than we would really like to admit. There are mothers, and y'all have, if you've been to clinical, you have seen, they come in and they're positive, okay? They're positive for more than just marijuana, okay? So be familiar with what NAS is, the long half-life that affects the baby of those drugs, and y'all know if they make it, if the mama even doesn't abrupt from cocaine, that's a good thing, right? So y'all know cocaine is abruptions, okay? That's significant, okay? Look on page, let's go back up here. So there's that chart again. Irritability, all of this right here is on page 366, guys, okay? So be familiar with these charts, okay? These are drugs that can treat a drug abusing mother, okay? These are some acronyms. All right, they may have facial anomalies. They can even be deaf, okay? Significant cardiac anomalies, okay? Fetal alcohol syndrome babies. We swaddle is that, so they sometimes they don't like to be held, especially if you have a baby that's on heroin or cocaine. They're very irritable. They don't like to be touched. So you just have to educate yourself on what to do with those babies. Okay. Discharge planning. I just want you to read through that, and knowing what to tell them. Okay. All right. That's the end of chapter 10.